Don't join from two devices.
No, ma'am, we are sharing same device.
Yeah, because there'll be echo otherwise.
Can we start?
Yes, we can. Um, Ruchir? Ruchir,
Piyush, just let us know, huh?
Yes, ma'am. Yes, ma'am.
can we start?
It's live now. You can start.
Yeah, we can. Yeah. Toshal, you can start.
Okay, thank you, ma'am. Good evening, everyone, and thanks for joining. I'm Dr. Toshali Panda from MGIMS, and on behalf of the Nagpur OBGY Society and Mahatma Gandhi Institute of Medical Science, I welcome you all to the next event of NOG's PG Star series. Today's topic of discussion is going to be on cervical malignancy. Today's topic, case discussion, is of utmost importance in the realm of modern medicine and healthcare, and the session aims to throw some light on the complexities, challenges, and advancement on the management of this condition. This is a knowledge sharing initiative by NOGS in association with MGIMS and Core Connect. So, without any further ado, I would request respected Dr. Sushma Mahajan, ma'am, to commence today's event. Thank you, ma'am.
One just correction, Sushma Deshmukh. Yeah. A very good evening to all. It gives me really today festival-like feeling to welcome you all for PG Stars series organized by Nagpur OBGYN Society with Mahatma Gandhi Institute of Medical Sciences, Sevagram. Thanks to Dr. Shuchi ma'am. And today we are going to discuss cervical malignancy. Friends, we know that though cervical malignancy is a hidden entity, it gives you symptoms and signs. It clicks our mind that something is wrong, something is odd, and you suspect that something is there and you try to find out. So be a master and lit up the light in many lives by learning all these pearls of wisdom. So today, Dr. Supriya took the challenge to become a master by preparing, by studying and presenting the case on CA cervix. Dr. Leela Vyas and Dr. Anuja Bhalerao, a brilliant examiners, decided to help this little master to ascend this ladder of success. So welcome Dr. Leela Vyas and Dr. Anuja Bhalerao and little master Dr. Supraja. But CA cervix is the most common malignancy, and one who wants to become really master must learn the surgical techniques. So here with us is the master of masters, Dr. Gopal Gurjar. He is going to speak on surgical aspects of cervical cancer. Welcome, Dr. Gopal Gurjar. Now, two genius chairpersons, gynecological master, Dr. Shuchi Jain, and medical oncology master, Dr. Sushil Mandhania, will give tips and tricks to complete the treatment protocol. Welcome, Dr. Shuchi Jain and Dr. Sushil Mandhania. Dr. Toshali Panda, she has accepted to view all these masters in one sitting. So I welcome all PGs and seniors friends. And the backbone of our PG actually, you know, Dr. Anuja Bhalerao, Dr. Bhakti Gurjar, Dr. Prachi Dikshit, and there are as usual the balancing masters and also of course my secretary Dr. Pragati Kharatkar. So just learn from the masters. And one thing remember, you know that the Nagpur Hysteroscopy Carnival is just very near. There's a 15th, 16th, and 17th December 2023 with 4 international faculties, with many, many star national faculties. So be there to witness this wonderful hysteroscopy examinations. So you will learn the surgeries and so many tips and tricks for the beginners as well as masters. It's a really academic feast. Thank you very much.
Thank you, ma'am, for your kind words. Now I'd like to introduce our chief examiners. Our first chief examiner, Dr. Leela Vyas. She has been a former senior professor and unit head, IVF consultant, member of Research and Review Board, SMS Medical College Jaipur, senior resident and various other institutes. She has been associated with Dakshita and Lakshya Mentor, NHM Rajasthan. She has been the chairperson of ISR Rajasthan, vice president of FOXY, president secretary of Jaipur Obs and Gynae Society. Our next chief examiner is Dr. Anuja Bhalerao. She is currently the professor and head at NKP Salvi Nagpur. She's got a 32 years experience at teaching in this department. She's got special interest in neurogynecology. She's got numerous publications in both national and international journals. I would like to request ma'am to join on screen. Thank you, ma'am. Now we'll proceed with a case presentation by Dr. Supraja Pachipolisu.
Thank you. Thank you, Bob. Supraja, start your case.
Yes, yes. Good evening, everyone. Today, my topic was on case presentation on CA cervix. I'm Dr. Supraja, and coming to the case, Mrs. ABC, 54-year-old, resident of Varda, educated up to 6th standard, homemaker by occupation, married to Mr. D. Educated up to 8th standard and expired 3 years back, belonging to class 4 BJ Prasad scale, presented with a chief complaint of foul-smelling vaginal discharge since 2 months. History of presenting illness. Patient was apparently well 1 year back, after which she developed foul-smelling vaginal discharge on and off, serosanguinous in nature, not associated with any bleeding. It was not associated with any abdominal pain or distension. The patient had a history of easy fatigability since 1 month, history of constipation since 1 month, and history of loss of appetite and loss of weight. No history of multiple infections of genital tract, no history of blood in urine or bladder problems, no history of bleeding per rectum, no history of back pain or leg pain, no history of hormonal drug intake or topical application, no history of cough or hemoptysis, no history of shortness of breath or palpitations. Her past menstrual history, age of menarche was 14 years of age, and which is regular 28-day cycle, bleeds for 5 days, not associated with any dysmenorrhea, and she changed 2 to 3 pads per day. And her perimenopausal phase was uneventful, regular 28-day cycle, bleeds for 5 days, not associated with dysmenorrhea, changed 2 to 3 pads per day. Age at menopause 50 years, attained menopause 4 years back. Obstetric history. She was married at the age of 19 years to Mr. D. Her husband expired 3 years back in a road traffic accident. There is no history of any use of any contraception or infertility treatment. And her obstetric history was she's P5L5, all full term normal vaginal deliveries, which are institutional deliveries, and she had given breastfeeding in all the children, and all the children are alive and healthy. And her last childbirth was 23 years back, uvectomized 23 years back. And her past medical and surgical history. She is a known case of hypothyroidism since 3 years on tablet levothyroxine 100 micrograms OD. There is no history of hypertension or diabetes mellitus, asthma, tuberculosis, renal diseases, cardiac illness, or any other major illness. No history of blood transfusion or drug allergy. No history of any sexually transmitted diseases in both the husband and wife or pelvic inflammatory disease. Family history. There is no history of hypertension or diabetes, asthma, tuberculosis, renal disease, cardiac disease, or any other chronic illness. No history of ovarian, GI, breast, cervical, or endometrial malignancies in the family. Personal history. She is a non-vegetarian. Her normal bladder habits and constipation since 1 month. Normal sleep and appetite. No history of substance abuse. Monogamous relation of both husband and wife. Coming to general physical examination, the patient is conscious and she is oriented to time, place, and person. And she is moderately built and nourished. Coming to the parameters, height, she is 160 centimeter, weight 51 kgs, BMI 19.6. Coming to the vitals examination, her pulse rate was 78 per minute and BP 112 by 70 mmHg, sitting in a comfortable position. Respiratory rate 18 per minute, temperature 97°F. And there is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. Systemic examination. Cardiovascular system S1, S2 Hertz, heard, no murmur. Respiratory system normal vesicular breath sounds heard, no added sounds. Central nervous system no focal deficit, and spine and gait are normal. Breast no lump palpable. Thyroid no neck swelling. Abdominal examination. After emptying bladder and taking verbal consent, patient is asked to lie in supine position and abdomen exposed till sternum. Coming to the inspection, abdomen which is normal in shape, all organs move equally with respiration. Umbilicus is midline and inverted. No or sinus or fistula, dilated veins or visible peristalsis. Hernial orifices free. On palpation, her abdomen was soft, non-tender, no guarding and rigidity. Was palpable. No inguinal notes palpable. Percussion, tympanic note present. On, on local examination, no excoriation of skin seen, and her vulva was normal. Labia majora and minora was normal. Urethral orifice was normal. Per speculum examination, exophytic growth of about 5 into 5 centimeters.
Voice is. Hello?
It is not audible.
Hello, you're not audible.
Am I audible, ma'am?
Yeah, now you are.
Okay. Coming to per speculum examination, exotic growth of about 5 to 5 centimeters, which is regular, which is replacing the cervix, and upper 1/3 anterior and posterior vaginal walls are also involved. Her fornices are obliterated and foul-smelling serosanguinous discharge was present. On vaginal examination, exophytic variable growth of about 5 into 20 over the cervix, which bleeds on touch. Uterus is felt separately from the mass and is of normal size. Bilateral fornices are involved. Upper 1/3 of anterior and posterior vaginal wall are involved. On rectal examination, rectal mucosa was free and bilateral parameter involved, not up to the pelvic wall. No nodularity or deposits in pouch of Douglas, and above findings were confirmed. Case summary. Mrs. ABC, 54 years old, P5L5, belonging to a low socio-economic status with the chief complaint of foul-smelling vaginal discharge since 2 months and with appetite and weight with BMI 9.6. On general examination, patient was moderately built on nourished. On per speculum examination, there is a growth of 5 into 5 centimeter, which is replacing the cervix, and it is involving the anterior and posterior 1/3 of the vagina. On bimanual examination, there is a friable growth of 5 into 5 centimeter, involving the anterior and posterior 1/3 of the vagina, which bleeds on touch, and uterus is felt separately from the mass and is of normal size, with bilateral fornices are involved. On per rectal examination, bilateral parameter involved, not up to the pelvic wall, and no nodularity or. My provisional diagnosis was 54 years P5L5 is probably a case of CA cervix with clinical stage 2B.
Hello.
The investigation register was routine blood investigation, which includes general CBCPS, liver panel, renal panel, sodium, potassium, blood group, urine routine microscopy, urine culture and sensitivity, and all the viral markers, sugars, coagulation profile, and chest X-ray, USG, abdomen and pelvis, MRI, CECT, cystoscopy, sigmoidoscopy, and FDG.
You are saying 2B, no? Hello?
Yes, ma'am.
Would you like to specify
Am I
anything?
audible, ma'am?
Hello? Would you like to specify more
Yes, ma'am.
as far as the clinical staging of CA cervix is concerned?
Yes, ma'am. Ma'am, CA cervix is mainly diagnosed on the clinical
No, my question is very
histopathology.
different. My question is very different. You said she's CA cervix clinically stage 2B.
Yes, ma'am.
Anything else as per the recent clinical staging? Would you like to add something more? The size is more than 4 centimeters, no?
The size is more than 4 centimeters, ma'am.
Okay. How will why you are saying that it is probably CA cervix? What are the differential diagnoses that you have with you?
Ma'am, my differential diagnosis are tubercular cervicitis and syphilis cervicitis and HPV infection with acute warts.
She's got a
Warts were
big,
present, and
she's got
ma'am,
a big growth, no?
yes,
The
ma'am,
big growth.
and it
So how
might
you
be
can say
polyp or cervical
cervicitis?
fibroid and the chronic cervicitis.
No. What your clinical examination you are telling? Just you have mentioned. No, don't go.
Yes, ma'am.
I remember that. One, you are saying that there is a growth on the cervix. Okay. And then on PS, you
Yes,
are
ma'am.
able to see that there is a vaginal involvement. So how the cervical fibroid you can bring in between that? And another bad thing is that once the vagina is involved, anterior, posterior, both vagina involved, laterally, partially the fornices are there. Are you able to feel separately uterus by PV examination?
Yes, ma'am.
You can feel it.
Another important thing that you said that the patient has got a friable growth which bleeds. What is your concept regarding doing a PV examination in a patient of CA cervix with such a big growth? Are you justified in doing a PV examination, or what type of examination would you like to go in for?
I would like to go for rectal examination, ma'am. Per rectal examination
Okay.
to know the exact size of the uterus and to know the cervical involvement and to know the parametrium involvement.
Okay. How will you differentiate between, okay, what you will feel as far as the parametrial involvement is concerned? How will you know that?
Mm.
What will you feel?
Mm. On per rectal examination, I can feel there is something hard structure and nodularity. Any
Nodular
nodularity is seen
Uh,
or any
Nodularity
deposits
is
or
never a
any.
feature of a malignant involvement.
Okay.
It will be indurative in nature.
Uh, induration and
Okay, one more
per
question
rectal
I would
examination.
like to ask you. In your history taking, in the husband died 3 years before this particular, when she came to you. Did she had any history of postcoital bleeding prior to that you haven't asked for?
Ma'am, she does not have any postcoital bleeding, ma'am. She
That is
had
a very
all this.
important symptom.
Yes, ma'am.
What are the 4
She,
signs and 4 symptoms of CA cervix?
ma'am, the four symptoms and signs of CA cervix was first one, postcoital bleeding, which may be sometimes it may be intermenstrual bleeding, or next foul smelling vaginal discharge and the cachexia, and there might be obstructive uropathy.
Symptoms.
Symptoms.
4 symptoms and 4 signs.
Ma'am, postcoital bleeding, ma'am, foul smelling vaginal discharge, and intermenstrual or bleeding and spotting in between the menses, and loss of weight, cachexia.
Okay.
And any urinary problems.
Okay, you said that the staging is of CA cervix is stage 2. What is the difference in the FIGO staging of cervical cancer as far as the latest guidelines are concerned, 2018? What has been included in the staging now? And previously,
Ma'am,
how was the staging done?
Ma'am, now the staging, it includes the radio radiological findings and also along with the histopathological findings, ma'am.
Yes. So previously, we used to stage the disease by inspection, palpation, then cystoscopy, proctoscopy, and all was mandatory. But nowadays, you can take the help of imaging and pathology for staging of CS cervix. That is a very important thing as far as staging is
Yes, ma'am.
concerned. Okay, ma'am, over to you.
Yeah. Which imaging you will go with that? Would you like to go first the biopsy in these cases, or you will go first the imaging? Because there is a friable
Ma'am,
growth. And all.
as it is a visibly clinical growth, so I will go for the biopsy, ma'am.
Which type of biopsy you will take in this case?
Ma'am, I would like to go for wedge biopsy, ma'am.
Wedge
When there is
biopsy.
a visible growth is there. What is wedge biopsy? In wedge biopsy, why we are taking for the wedge biopsy? Which part of the cervix we are taking in wedge biopsy?
Ma'am, why? Because in CSF weeks, there will be central necrotic area. So in the wedge biopsy, we will take from the margin so that we can get the normal tissue as well for the histopathological clinical examination review, ma'am. Comparison.
No, here you have explained there is a big 5 centimeter growth which has replaced completely the cervix, and even the vagina anterior and posterior part, upper 1/3 has been involved. So where the margin, the clear margin, where will be the clear margin? Wedge biopsy it will take in this growth, or you'll go with some punch biopsy from a non-necrotic area?
A punch biopsy.
And then I will go for the punch biopsy from the non-necrotic region, ma'am.
Yes. So where you are taking wedge biopsy? In which type of cases?
Ma'am, it will be taken when there is normal cervical tissue along with the growth, ma'am. So that
If it
there
is
will be
without
tissue for
growth and
comparative study.
How will you collect the
Less
sample?
than
If
4 centimeter lesions.
take that wedge biopsy, just because this is always in your, I think they are also asking in your pre-PG examination, there is MCQ, where you will take by wedge biopsy, where you will take the punch biopsy. This is a very common question usually you are having. So wedge biopsy, what is the
Yes.
concept behind that wedge biopsy? When the cervix, we are suspecting any CIN3 or you have grade 3, this in your colposcopy and in
Yes.
your PAPs, you are in doubt that. If you want to confirm, then which part of the cervix you are, how will you take that wedge biopsy?
Ma'am, wedge biopsy is taken from the margin of the growth
No,
where the
I'm
normal
saying no
tissue.
growth. The growth is not visible.
So we can go for colposcopy and colposcopy guided biopsy we will take, ma'am.
So that's why I'm asking you what it includes. Which part of the cervix is included in this wedge? What do you understand by the wedge biopsy? Because this basic thing, if this patient had come 3 years before and she was complaining, I am having a postcoital bleeding, and you have done pap smear, you have done HPV DNA, it comes out positive, you have gone through that colposcopy also, and you are suspecting that is in the means CIN3 types or any of this Pitata system, you go with that suspicious, and you want to take a biopsy. Then how you could have taken that? How you will take that wedge biopsy in case of this where the no visible growth is there, but you are suspecting?
Ma'am,
Which
we
part
will
of the
apply
cervix is initially involved?
which part of the cervix? It is the anterior lip of the cervix. No, it is the posterior lip of the cervix which is most commonly involved.
listen, very important that madam is asking you is, if the lesion is visible, it is very important for all the postgraduates to understand that if the
transformation
lesion
zone,
is
ma'am.
visible, transformation zone is only seen on a colposcopy. If the lesion is visible, we would always go in for a punch biopsy. If the lesion is not visible, you can either go in for a leap or with the help of a cone biopsy, and you can get a sample for collection for diagnosis. Okay. So
Yes,
what would
yes,
be
ma'am.
the histopathological types of CA cervix that you can get on histopathology?
Ma'am, we will get a squamous cell carcinoma, and in the squamous cell carcinoma, there are subtypes which may be keratinizing and non-keratinizing small cell carcinoma, and other type is verrucous carcinoma. And when compared,
Of all these
and
that you are
another
telling
was
us, which has got the most dreaded prognosis?
adenosquamous carcinoma, which is of a glassy cell type, carries the most worst prognosis, ma'am,
And clear cell also.
and clear cell carcinoma.
What do you understand by grading?
Ma'am, grading it mainly depends upon the whether it is well differentiated or not, ma'am. If the cells are well differentiated, mildly differentiated, moderately differentiated, and not differentiated, ma'am, undifferentiated. So according to that, we will grade it as a
Why do you think
mild,
the
moderate, and
staging of
severe
disease is
grades.
important?
Ma'am, for operability, ma'am.
Only operability?
Uh, Ma'am, it
See,
also
whenever
tell
you
whether
are
we
asked a
have to
question like this,
go for any other chemo radiation or not.
okay.
And also according to the age and according to the stage, our treatment modalities will also change.
Very good. Okay, so your answer should be to identify the most appropriate treatment and to minimize the dual treatment, because every dual treatment is associated with lots of morbidity. So you want to really know what is going to be the most appropriate treatment for my patient. So that is the most important staging of CA
Yes.
cervix. Okay, over to you, ma'am.
So,
Yes.
if as ma'am has already mentioned you that extent you have to say, if a patient comes to you that involved, you have done the PR examination and you have done the this imaging, what other anything you are doing, some mildly invasive to nearer structure to see that cystoscopy you are doing or not in these patients, if you suspect, because anteriorly the wall is.
I will go for cystoscopy also, ma'am, to know the bladder involvement. And I will go for sigmoidoscopy also to know the extent of the rectum involvement. And I will do the chest X-ray also, ma'am, to see whether any metastasis are present or not. I know the staging was clinically 2B only, so I will just do all this investigation to rule out any other metastasis. And simple USG will show any other mets in the liver or not. And simple renal function test and liver function test will also tell whether the patient has any abnormality or any deranged panel can be found out by routine investigations too, ma'am.
Listen, I
And
would like to
IUP
just
also we can do, ma'am, to
I
know
would
the
like
course
to
of
just
the.
interrupt you here. Doctor, actually, as per the very important change as per 2018 FIGO, nowadays cystoscopy and proctoscopy is not absolutely mandatory. It is to be recommended only if you have some
Yes.
clinical findings
Clinical
and
findings.
if you are deciding for a standard of care.
Yeah.
Okay,
Yes,
so
ma'am.
your answer should be that for all patients, it is not
But not all
mandatory
patients.
for you.
Yes,
If
ma'am.
suspected is there,
Yeah.
then
Only when you are suspecting
suspected,
involvement.
then
It is
you
only
are
yes,
going
ma'am.
with this.
Okay.
So
Go
this,
ahead, ma'am.
have you come around any time you have got any call because you are in medical college? In our time, you used to get a call from the urology department that the patient come as with the renal failure. And the patient complaining of bleeding PV in the midnight, we are getting a call that come and do a examine the patient. The gynae ward, we are getting a call that you come for a patient examination, patient complaining of bleeding PV. This scenario have you seen nowadays? What it indicates?
Yes, ma'am. Yes, ma'am.
Why the patient has been admitted in urology, nephrology department as a case of a renal failure?
Yes, ma'am. We used to get calls from the same urology and surgery department, ma'am. The patient was admitted for some renal failure or for something reason, and the patient complaining of bleeding PB and all these things. We used to get the
No, no.
calls.
Why? Especially the cancer cervix patients.
Yes, ma'am.
Ma'am, Anuja ma'am, you must have come across these conditions.
Yeah,
And the
yeah.
patients, the whole involvement of the kidney, because the extent it is going at the time when we were not having the MRI and all.
Yes.
We were just the
The patient
clinical
used to go to the renal unit with uremia.
uremia.
Yes, ma'am.
Because they come and we used to get the call, and the first year resident always said that no, क्या है रात को 9 बजे we'll go and do a PV examination. And the morning your teacher is scolding you, why not you have gone that the patient is ours. She is the case of CS cervix. So these were the cases we have seen. Because now with the imaging and all, because they go for the imaging immediately and they get this diagnosis. But initially it was only the time. It was, ma'am, in our time it was there. I have faced these problems during my residency, even my lectureship and all. So many calls has been attended. So this extent that, as Madam very rightly said, that treatment is chosen as how this is extended up to that. So what we call it as a bladder and rectum is involved, and you have to decide which type of therapy you will give to these patients. Even if you have chosen chemoradiations, what we call this terminology, still the role of the palliative therapy is there or not?
Yes, ma'am.
What do you understand by that?
There is still role of palliative radiotherapy also, ma'am, in the patients who are inoperable and where the patient is advanced CS cervix, where there is whole metastasis to relieve the pain and all the symptoms. There is palliative radiotherapy also.
Okay, as we are coming to the treatment modality, we'll just brush up our things. What are the various changes that have occurred over the FIGO staging? You can just tell me 4 important changes that have occurred in FIGO staging, and then we go to treatment first.
Yes, ma'am. In now the FIGO staging, previously when it is involving up to the pelvic wall and lateral up to the pelvic wall, it is considered as an advanced 3C. Now if it is extending to the pelvic wall and if there are any hydronephrosis or any other changes, it comes under stage 3B, ma'am. And in stage 1A, 2A1 also, there are 2 subcategories. 1A1, 2A1, which is less than 4 centimeters, but it is involving the upper 1/3 of the vagina, and 2A2, which is greater than 4 centimeters and involving the same upper 1/3 of the vagina. And even there, in the stage 1B2, there is a less than 4 centimeter lesion, and another was same bulky lesion in the 1B2 also.
Okay,
And
so
in the 1B3, it is greater than 4 centimeter, but not at all involving the vagina.
And anything else in 3?
In
Involvement of the lymph
stage
nodes?
3C1, there is an involvement of the para-aortic lymph nodes and pelvic lymph nodes also. It is categorized into 2. 3C1 which is involvement of the pelvic lymph nodes and paracervical, and 3C2 it is the involvement of the para-aortic lymph nodes.
Okay, so most importantly, radiology as well as pathology have been included.
Pathology.
Second important change, in stage 1, the lateral extension measurement has been removed. We are not counting width, we are only counting the depth of invasion. Then 1B is transformed into 1B1, 1B2,
1B2 and 1B3.
Then we have stage 3, there is a change with involvement of lymph nodes. And most importantly, nowadays cystoscopy and proctoscopy are not mandatory. They are to be done only when they are required. Okay, so these are the changes as far as the postgraduates are concerned. Now moving to the now that you've got your diagnosis that she's a case of CS cervix, what are the very common types of CS cervix that you get? What histopathological reports you will get?
Ma'am, most commonly we will get squamous cell carcinoma, that too most commonly keratinizing type of the squamous cell carcinoma.
Okay. How do what do when will you call it as early stage CA cervix and late stage CA cervix? How do you classify that? Early stage means what?
Early stage CA cervix, when it is involving, when the size of the lesion was less than 4 centimeters, and there is no pelvic and para-aortic lymph nodes involved. Until stage 2A, it is known as early stage disease.
Very good. So whenever you have a disease which is less than 2A, which is operable and the size is less than 4 centimeters, we would label them as early stage, and later
Early
would be
stage.
late stage. Your patient has got stage 2B. Stage 2B. Why it is important means how would your management change with stage 2B?
Ma'am, until 4 centimeters of the lesion, we can go for the surgery and followed by the chemo.
Stage 2B, doctor.
Nice. Stage 2A tak, ma'am. After stage 2A and from stage 2B, we will go for chemo radiation as the primary modality of the treatment.
Chemo radiation.
Yes,
so now that you have planned for chemo radiation, how are you going to prepare your patient for chemo radiation?
For chemo radiation, I will go for the routine blood investigation, ma'am, because
that you have already done. You tell me what is
HB was
radiosensitizers.
important. Ma'am, radiosensitizers or newer chemotherapy agents like cisplatin and flunidazole and tumor necrotic factors and interferons. These are the these are the chemosensitizers, ma'am.
Okay. So how are you going
These are
to
the
go about?
radiosensitizers. So I will give first 5 cycles of chemo radiation with the cisplatin, ma'am, which is a radiosensitizer, and which is of 40 to 45 mg per meter square, and we will give for weekly for 5 weeks. And then after I will go for radiotherapy. And even in the radiotherapy, I will, if it is a large tumor size, first I will go for a teletherapy because it shrinks the tumor volume. And then I will go for brachytherapy.
Okay, so external beam radiation and
external beam radiation and followed by intracavitary brachytherapy.
What is the recent modality of brachytherapy?
In the recent modality, it is intensity modulated radiotherapy, and which also includes the 3D MRI radiotherapy we are giving, ma'am. And in that also now we are giving high dose rate iridium 192 with the help of that high dose rate, we are giving it that too in fraction dose also we can give pulsed doses.
What is the difference between low dose rate and high dose rate?
Ma'am, actually low dose rate we use with cesium-137, ma'am. So actually it requires hospitalization of the patient, and whereas high dose rate it and in the low dose rate it gives us very low fraction 2 gyries only per hour, whereas in high dose rate it can give 12 gyries per hour and it can be done within very short time, and it does not need any hospitalization. And even in the OPD basis also, with the help of the remote control, we can do the high dose rate with the help of iridium 192. And
your patient had a big mass. You did a PV and she starts bleeding. What is the role of hemostatic radiation?
Ma'am, hemostatic radiation can, if the patient is bleeding, ma'am, first we can do the packing for the patient, and we can give the thromboprophylaxis. We can give IV tranexamic acid, and even after that also, if we cannot control the bleeding, we can apply Monsel's paste, ma'am. And even after that also, if we do not control the bleeding, and we can go for hemostatic radiation, ma'am.
Ma'am, over to you, ma'am. Yes, ma'am.
Yes, yes. I'm asking as the question I would say, hemostatic. Can you go with the concomitant chemo radiation in these patients? Sometimes required if the bleeding is not controlled.
Ma'am, I can't hear.
No. Concomitant chemo radiation can we proceed if the patient is bleeding and not?
Ma'am, I'm not audible.
Surgical aspect of cervical.
Hello, somebody's. Hello.
Hello.
Can you please mute your
Am I audible?
telephones?
Am I
Please
audible?
mute your Are you able to hear her question now? Hello?
Yes, ma'am. Yes,
Ma'am, you can
ma'am.
ask the question again.
Yes, I'm asking, is there any role of nowadays that concomitant chemo radiation sometimes we required, as Adam has mentioned that these patients are bleeding and all? Because
Yes, ma'am, concomitant chemo radiation, yes, ma'am, it is of no use, ma'am. Concomitant chemo radiation, we will give the chemotherapy, and along with that, we can start the radiotherapy too. Brachytherapy also will take 5 weeks. External beam radiotherapy, we have to give for 5 to 5.5 weeks. So along with chemotherapy, we can start the external beam radiotherapy, then followed by intracavitary brachytherapy, ma'am.
so what the results are saying, whether the sequential we are going or with this? Because initially we were using.
The results are telling that even if you go sequentially, there is the same 5% survival rate. OS is the same, and in even some people are stating that if we go concurrent chemo radiation, we can treat the patient a bit earlier, and but the OS was same for both the trials, ma'am.
Okay.
And the
So,
concomitant was a bit superior.
as per the recent guidelines, is there any role of sentinel node mapping in patients with CS cervix?
Yes, ma'am. There is a role of a sentinel lymph node, ma'am. For sentinel
in patients with CS cervix?
Yes, ma'am. Yes, ma'am.
Even
if we in the intraoperative, if we do sentinel lymph node testing with the detection 99 in the intraoperatively, the sentinel lymph node in the CS cervix was obturator lymph nodes, and if the obturator lymph node was positive, and we can do the pelvic lymph adenectomy, ma'am.
Okay. What is
At
the
the
age
same
of your
setting.
patient, you said?
Ma'am, the age of the patient was 54 years.
54 years. So she's a young lady. So
yes.
Is there any place of minimal invasive radical surgery for early stage CS cervix?
Minimal, yes, ma'am. For early stage CS cervix, there is minimal invasive surgeries are present, ma'am.
In which patients?
While
Early
coming
stage
to
means?
stage, ma'am, if it is less than 4 centimeters in involvement,
Less
ma'am.
than 4 centimeters.
Yes, ma'am.
Okay. If it is more than 2 centimeters, there is no role.
Ma'am?
If the size of the tumor is more than 2 centimeters, there is no role, because the overall survival doesn't get affected even with surgery or with radiotherapy.
Surgery and the radiation, ma'am. Yes,
what is a nerve sparing radical hysterectomy?
Ma'am, nerve sparing radical hysterectomy, it is known as type 3C1 radical hysterectomy, ma'am. Actually, we are doing this to preserve the bladder function and any other sexual dysfunction to prevent, ma'am. In this, we are preserving the hypogastric nerve, inferior hypogastric nerve, pelvic splanchnic nerves, and the hypogastric superior hypogastric nerves, so that the bladder dysfunction is a bit less and sexual dysfunction also less, ma'am.
Okay. So can you just highlight, if the patient is young and suppose she's 1A, sorry, 2A, what would,
2A.
Yeah. There are two patients. One patient is 54 years, as is yours. Another patient is 74 years, who both of them have got 2A. What would be the mode of treatment you would like to go in for both of them?
Ma'am, for young patients, I will go for surgical treatment only,
Why?
ma'am, because in surgical, we can preserve the ovaries, ma'am, and there will be less stenosis of the vagina. When compared to the radiotherapy, in the radiotherapy, there will be stenosis of the vagina, and uh, and there will be more osteoporosis related problems if we remove the ovaries in an young
Can you?
female. So for ovarian
Why you want to
preservation,
remove the ovaries? You can always. What other way you can go in for by how you can prevent the radiation damage to the ovaries?
ma'am, we can prevent radiation damage to the ovaries by giving intensity modulated radiotherapy so that we
Anything
can get the
intraoperatively
specific.
that you can do?
Ma'am, we can pack them.
Pack?
Sorry, I don't.
Where are the ovaries placed during surgery to prevent them from radiation exposure? They are always put into the.
We can put them in the pouch of Douglas.
Pouch of Douglas. You are not going to
No,
put
sorry,
them in
we
the
can put in
pelvis.
the. Ma'am, I don't.
situation.
Hello.
Ma'am.
You will always place them at a higher level so that you are
Yes.
preventing them from getting any radiation. So during
Yes, ma'am.
during surgery, you can place them at a higher level. The ovaries can be
Okay.
placed at a higher level.
Kept it at a higher level, placed in a higher level.
What are the various types of hysterectomies you know of as per the classification?
Ma'am, first type
How many
1
are
is
there? You
a
tell me
simple.
first.
Ma'am, total there are 5 over there, ma'am, but we are
5
not at all
classes.
doing type 4 and type 5 now. And we are only doing type 1, which is
Suppose your
simple or
patient would
extrafacial.
have been young. She wants to
Yes, ma'am.
conserve the uterus or her fertility. What are the various fertility sparing surgeries? Until
Ma'am,
what
various
stage you
fertility.
can do them?
Yes, ma'am. Until what stage? First stage until 1B1, we can go for fertility uterus preserving surgeries, ma'am. There, if it is stage 1A1 without any lymphovascular space involvement, we can go for conization. And if it is with a lymphovascular space involvement in 1A1 and 1A2 and 1B1, we can go for radical trachelectomy along with pelvic lymphadenectomy.
What are the 5 important steps of radical trachelectomy with lymph node dissection?
Ma'am, the steps that included are we can do abdominally or laparoscopically. First, while doing, I will prefer abdominally, ma'am. We have to identify the cervix at the level of the internal os with 5
No, you
mm
only
of
tell the principles. We don't want the details. Only the principles.
Ma'am, we will, there will be 5 mm of endocervix tissue along with the uterus we will keep, ma'am. And the cervix was removed and it is tied post, and it is removed, ma'am. Then we will go for the pelvic lymphadenectomy. Basically, uterus and along with 5 mm of endocervical fascia were kept in situ in trachelectomy, ma'am.
Okay. So you have to know in details the principles.
Yes.
Number 1
Yes,
would be laparoscopically or abdominal
Lapis.
dissection of the lymph nodes till paraortic. Then anterior
Paraortic and
dissection, posterior dissection, removal of the cervix with the parametrium, and attaching the
Parametrium.
vagina to the uterus with the help of McDonald suture. So
McDonald's
these are the
sutures.
5 important principles. Over to
Yes,
you,
ma'am.
ma'am.
So, in these patients, what means you have done? One is the in uterus preserving surgery you have done, what precautions you will take while in these patients? Since, as Madam asked, what is the age limit at what you will preserve this? Cervical cancer is usually at which age commonly?
Ma'am, actually, cervical cancer presents with bimodal presentation, ma'am. One, it is at young age like 35 to 45 years, and one is at a 60 to 69 years range. So it is bimodal in age distribution.
Sure.
So until like ovary preservation, ma'am, you're asking about ovary preservation only,
no, I'm asking about the fertility preservation. Ovary is preserved for so many other reasons. A patient, even in the
fertility
35 to
preservation.
40 years, we need an ovary. So, what are the different functions of the ovary? You just said. But in before this fertility preservation, what means you are preserving uterus? You are means fertility preservation means the uterus you are also preserving in these patients in the early stages of that. So, what are the prerequisites for that? Means any patients that what is the demand of the patient? Why you are preserving that?
Ma'am, the demand of the patient was when her family was not completed, when she wants to conceive in the future.
So you want to investigate whether a case of a primary infertility comes to you, and since you want to take a proper history and investigate that whether she is what was the cause of the infertility in this patient. Would you like to
Yes,
see
ma'am.
that and then start with this? Because always the
I will
patients
like
are
to
scared
see.
of that.
First, I would like to go and investigate for the primary infertility. What was the cause for the primary infertility? Then I will rule out. Then only I will go for further treatment for the patient.
After doing trachelectomy, what is the chance of her conception, and what would be the mode of delivery in these patients?
So what
Ma'am,
precautions
the mode of delivery in that patient is a C-section only, ma'am.
A classical one.
Classical C-section only.
Okay.
And before that, what other thing? In antenatal period, you have to take care of any internal loss.
Yes, ma'am. We have to take care of the internal loss. The patient will have might have a first and second trimester abortion, matlab early pregnancy loss because of the cervix, short cervix, because of the removal of the cervix. We can have early pregnancy loss, recurrent pregnancy losses will also be there. So we will ask her to take the rest, and we will go for elective classical LSCS for the patient, ma'am.
Other thing, any cervical incompetence has that also.
Yes, ma'am. There will be cervical incompetence for the patient.
So what we can do?
Ma'am, for the cervical incompetence, we can give medical progesterone therapy.
Any surgical intervention which we can do? Encircular?
Ma'am, there is already McDonald's in situ. So,
yeah.
So,
how much is the chance of conception?
So it is not needed.
Chances of conception
and take home baby rate.
There will be decreased chances of conception, ma'am. Then the woman can go for IVF also, ma'am.
Okay. You mean to say surrogacy?
Yes, ma'am.
Okay. So that is another way.
Again, you have any idea of this surrogacy law? That has come under, which is a big problem for us. Still, it has not started.
Still, it has some social stigma, but surrogacy is a very good option for
there are
people.
very strict surrogacy laws these days. There is something called as traditional surrogacy, gestational surrogacy, and you need to know everything about it.
Because before counseling that, we have to say that whether in this, because this time every state has not launched their rules and regulations, so still struggling with that surrogacy.
Prachi, so, how many more minutes do we have? Hello? Bhakti?
Ma'am, we have 5 more minutes.
Huh?
So one thing is that any procedure you are choosing and what we want to do further, that counseling is required whether the patient wants to go for these options or not. That is again,
Yes.
so any means procedure which is need a proper counseling also.
Yes, ma'am. Every
Suppose you
procedure
have a
requires
patient.
proper counseling.
Suppose you have a patient who's antenatal in the first period, first trimester with CA cervix stage 2B. How will you manage?
Ma'am, if it depends upon the whether the patient wants to continue her pregnancy or not, ma'am. Mostly in the stage 2B, the treatment modality is even if she wants to continue also, the treatment modality was chemo radiation only, ma'am. But if it is stage 2B, ma'am, if the period of gestation was less than 22 weeks, we can go for less than 14 weeks. We can give the chemo radiation with the products of conception in utero, ma'am. But if it is greater than 14 weeks, we can go for the hysterotomy. And after that, we can give the chemo radiation in stage 2B.
You
If the
need to
patient
read.
is pregnant.
You need to read CA cervix complicating pregnancy. You're not right. Okay. What are the various complications you can have of radiotherapy, and what are the causes of death in a patient of CA cervix?
In the complications of radiotherapy or most commonly while brachytherapy, because of the tandem perforation, there are more chances of the death. And after that, the patient can have a fistula formation, and there is a strictures, ureterovaginal fistula, vesicovaginal fistulas will be there, and there might be
See,
intestinal
whenever you are
obstructions
answering
also for
such
the patient.
questions, you need to divide them as immediate, late, delayed
Immediate, late, and
complications. Okay,
ma'am.
so you
Immediate
always, whenever you are
complications.
answering in exam, if you want to get more marks, you have to answer systematically. So you will
Yes, ma'am.
always say immediate. So what are the immediate complications, delayed,
Ma'am, the
late
immediate
complications, and delayed? What are the causes of death in CA cervix?
The causes of death in CA cervix were mostly uremia, obstructive uropathy, because of uremia and obstructive uropathy, and renal failure.
Everything is same. It is the only answer. What are the other causes? Hemorrhage is another one,
Hemorrhage, torrential
and
hemorrhage.
cachexia. These are the three important causes. What is primary, secondary, and tertiary prevention? And what is the role of immunization, HPV immunization?
Yes. Ma'am, primary prevention is, ma'am, actually CA cervix is one of the cancer which can be preventable, ma'am. So primary prevention is by HPV vaccination, ma'am. And in the
Primary
HPV
prevention.
vaccination, we have three kind of vaccine. Primary
What is
prevention is by
primary
HPV
prevention?
vaccination and cervical by screening methods. Screening, ma'am.
Primary prevention.
Primary prevention is cervical screening and HPV vaccination for the patient.
Primary prevention
wrong,
means the etiological factors you are going to prevent. You don't want the ladies
Yes, ma'am. Yes,
to get
ma'am.
married early, no early sexual contact.
At
These would be the
early
primary prevention.
contact and
Secondary
yes,
would be screening. What is downstaging of
yes,
CA cervix?
Downstaging of CA cervix was if you diagnose the patient as a higher stage, but you do not know whether it is confirmed, it is better to downstage the.
No. Downstaging is what is practiced in rural areas where you do not have facilities for pap smear. That you are training the ASHA workers to see the cervix, and if they find that they are abnormal, they should refer them to a tertiary center. Nowadays,
Visual
pictures are
inspection
taken
under
and pictures
acetic
are
acid
posted.
and
They have advised to do that VIA. They are
VIA
doing
and visual inspection under acetic acid and visual inspection under Lugol's iodine.
What is the causative organism that madam is asking that you have to prevent that?
Human papilloma virus.
How will you test this? How will you test for HPV? HPV DNA testing we are doing.
HPV
Yeah.
DNA testing, ma'am. We will take the DNA sample, HPV DNA testing by taking the sample from the in the internal os.
When do you start doing HPV DNA testing?
Ma'am, HPV DNA testing has to be done after 30 years, ma'am. While pap
Why
smear
not
can be
before
done
that?
after. Why not?
When should we
Secondly,
start
as
the
per the ASCCP guidelines, the recent guidelines, what is the change in the screening schedule?
Yes.
In the screening schedule, we have to screen the patient from 21 years of age until the 70 years of age, ma'am. From 21 years of age, we can go for pap smear and liquid-based cytology. And after 30 years, we can go for HPV DNA testing and co-testing for every 5 year. For pap smear, we go for 3-year testing, and HPV DNA co-testing, we can screen the patient every 5 years after 30 years of age.
So, this HPV DNA testing, are you doing routinely? Are you taking sample?
Ma'am, we routinely do pap smear and liquid-based cytology, colposcopy, BIA.
If you are doing liquid-based cytology, then same sample is to be sent for the HPV DNA.
HPV DNA testing.
Not to be it's a PCR. It should be HPV DNA type 2 hybrid capture type 2 test. Because the PCR is only for the research purposes. If the clinical use, it is the hybrid capture type 2 test, which is required. By that, you can detect that high risk strains of the HPV DNA. If a lady is comes at the 30 years you have done, and patient, what is the age when you start with the vaccination?
Ma'am, we can start the vaccination from 9 years, ma'am. And before the now the HPV nonavalent vaccine, we can give the vaccination from 9 years to 45 years of age, ma'am. But if it is before the 15 year, before the 25 years, we are giving only 2 doses, and after that we are giving one another booster dose, that is 0 to 6 months dose. And before that we are giving only 2 doses, which is 0 and 6 months. Whereas Gardasil vaccine is also which covers against 4 strains. We are giving 3 doses at 0, 2, and 6 months.
Or the monovalent. It is the 3 doses after 15 years. It's after 16 years of age. We are giving this three doses.
Yes, ma'am.
So is it necessary to do
Yes,
if a lady coming at the age of 35 years and she wants a vaccination? Is it necessary to do? She should have a report of HPV. HPV DNA test report you require.
Ma'am, actually, nonavalent vaccine can be given without any report also. But even if the patient is HPV positive, if the patient does not have any HPV DNA test report, we can give the vaccine shot to the patient. If the patient carries
testing, yeah, routine test we are doing, but not immediately any test is required. You can advise them to take vaccination without any test.
You can advise.
It's just one more
without
question.
any testing.
Whenever we talk about malignancies, we talk about tumor markers. Do we have any tumor markers for CA cervix?
Yes, ma'am. P53 and retinoblastoma gene.
Anything else?
These are the ma'am. For
Are
the
they
HPV, it is yes, ma'am. The HPV E6 oncoprotein is especially for the P53 oncogene, and E7 oncoprotein is for retinoblastoma gene.
Even cytokeratin.
And even
okay.
Ma'am?
Okay.
Yes, ma'am, cytokeratin. And even and E2 or the early replication proteins, we can also
can you just highlight what is transformation zone?
Ma'am, a transformation zone is a zone between the original squamo-columnar junction and the immature
Newly
new
formed.
squamo-columnar junction. Yes, ma'am.
Yes. Okay.
That's why I was asking you how to take a wedge biopsy. So the wedge of the base of the wedge will be from the external os. We go inside to the transformation zone and take that biopsy. And then that's why it should be included the transformation zone. And we can see
Yes,
that
it
any
includes.
initiation of the CSF starts from that. That is the point where the start. And that's
Yes,
why we
ma'am.
take the biopsy in a doubtful cases. Okay.
Especially in patients with
Very
CIN3.
rarely we take. Practically bone biopsy we are not taking.
We
Yes.
have to take the
Bleeding and
biopsy,
also.
including the transformation zone,
Yes.
because there the
Transformation zone,
HPV.
it is seen only on colposcopy. You cannot see transformation zone with your naked eye. Okay.
Right.
It is the
Yes, ma'am.
squamocolumnar junction from where you are taking the pap
Convention
smear.
which can be
When will
taken.
you call a
Yes, ma'am.
pap smear to be ideal for interpretation or adequate for interpretation?
If the sample size is adequate and the patient, like 10,000 squamous cells should be present, and there should be no any inflammation or cervicitis or any
Only
vaginal discharge,
squamous
which
cells,
is,
if they are present, you are fine.
and endocervical cells also
Yes.
should be present.
That is the
It
point.
also, the endocervical brush which collects from the endocervical region, endocervical cells also present, and
Okay,
actually,
that's okay.
if the
Okay.
patient
That's
is
fine. Are we done? Our time is over. Hello.
I
Yes,
think
ma'am.
so, yes, ma'am.
Okay.
Yes.
Thank you so much, organizers and Vyas ma'am. So nice to be
thank
with
you,
you.
Richa, for that. Nice. Thank you very much, sir.
Okay.
That's
Thank you.
it.
You've done good.
Suprita.
Yeah,
Hello.
it was really a very good discussion. A lot of things to learn. Really wonderful. Just I would like to add, now in this this carnival, there is very nice talk by Dr. Luigi Monteci. He is having wonderful work on histoscope as a colposcope. Very good imaging and very good. So I think you must attend and you must see this what he speaks.
Yeah, Suprita, when we are doing vaginoscopy, because
Yes,
on hysteroscopy, we go to do with the vaginoscopy. Once you distend the vagina, you see the cervix.
yes,
Means there is no need of going for that. Once for the colposcopy, you see each and
yes,
everything.
yeah,
Even once you enter inside, that so many things by the in hysteroscopy through vaginoscopy we are going. The cervical canal lesions we can see.
yeah.
So many
You can
polyps
go
are there.
ahead beyond that. You can go ahead also, and you can see
Huh?
what the extension of that lesion is.
Yes, that is can be
Very
seen.
important, just I would like to add. And he's working with the 80 magnification. What we are having 30. He's
We
having
have the
80
normal one.
so pictures
Which
are
scope
like
is that?
just like a microscopy.
My God.
So which scope he is using?
Hmm?
Because initially the Bitochi was also
But
that.
it's 2.9 mm. I'm using 2.9 mm 30 degrees.
Yeah.
And he
So
is a magnification 30 times and he's having 80 times magnification.
that. We'll do it online also.
We'll plan on because we want physical presence.
I have to go in some marriage because I
Yes.
saw your that.
We'll just see what the things do.
Thank you very much.
Yeah.
Thank you so much for a nice presentation. Hello.
Thank you so much, ma'am. It was a wonderful experience for me.
Congratulations. You read well. Yes.
Thank
But
you,
you
Anuja
need
ma'am,
to do
Leela
much,
ma'am,
much.
for taking our time and
Hello,
guiding the
hello, Shruti.
students. Yeah, hello, ma'am. It was really, they were really words of wisdom for us.
Most welcome.
Yeah.
Over to you, Prachi
Yes.
or Bhakti.
Supraja did very well. Huh? Supraja,
Yeah,
good.
Supraja, nice.
Yes. Thank you, ma'am, for giving this opportunity. Thank you. Thank you, Anuja, for sharing this.
Okay.
Thank you so much, ma'am, for this opportunity. Thank you. Thank you,
So
Dr. Supraja, Dr. Leela, and Dr. Anuja for such an interactive and educative session. I would now proceed further with the next phase of our event and like to introduce the chairperson of today's event. One second.
Today is Bhakti's day.
One second. One second. First chairperson I'd like to invite on screen, respected Dr. Suchi Jain ma'am, who's currently acting as who's head of department and professor at MJMS Sevagram. She has worked with many of the famous associations like NQOCN, Lakshay, ICMR, WHO, and has got many awards like late Dr. Praveen Mehta Fellowship in Endoscopy, Movicol Korean Award in Senior category in 2023. She also works as PG teacher and examiner in MUHS and DNB. She has got numerous publications in national and international index journals. She's also contributed in WHO manual for cervical cancer screening and contributed to the Book of Family Medicine. She has special interest in high-risk obstetrics and oncology. Ma'am, I'll request you to share few words of wisdom with us on screen.
Thank you, Toshali. Thank you, organizers, Sushma ma'am, Kharatkar ma'am, Dr. Prachi, Dr. Anuja ma'am. It's been a pleasure being associated with this PG series. It has been really been a lot of tremendous support and good learning experience for all our postgraduates. So we'll be moving on to our next session. Dr. Mandania is there? Sir is there? Do I have to introduce the chief guest, the speaker?
I'm available.
Okay.
Yeah, you can go ahead, please.
Okay, right. So we have Dr. Gopal Sri Krishna Gurjar, who will be our speaker for today's session. He is a consultant head of surgery at National Cancer Institute, Nagpur. He has done his MCH at Gujarat Cancer and Research Institute, Ahmedabad, and he did his general surgery and MBBS from Government Medical College, Nagpur. From 2012 onwards, he's been associated with National Cancer Institute, and before that, he was assistant professor with Medical College, Lata Mangeshkar. He has numerous publications and research in near total laryngectomy and role of tamoxifen. He has got prizes as first prize in surgical oncology and second runner-up for quiz oncology. And he has a logbook of surgical experience at GCRI, where he has done 866 assisted surgeries and 808 independent surgeries, which makes it a score of 1,674 surgeries. So all of us are eager to listen to this esteemed faculty on the topic of surgical management of CS cervix. Over to you, sir.
Toshali, I think
Yes,
the
ma'am.
second chairperson you have not introduced Dr. Sushil Mandania.
Yes, ma'am.
Please
Okay, ma'am.
introduce
Sorry.
Dr. Sushil Mandania.
Yes, ma'am.
Welcome,
Sorry,
Dr. Sushil Mandania.
I'll welcome Dr. Sushil Mandania, so also as second chairperson for today's event. He has done his MBBS and MD in internal medicine from GMC Nagpur. He has done his fellowship in adult and pediatric oncology and bone marrow transplant from Tata Memorial Bhopal and DM in fellowship in medical oncology from AIMS New Delhi. He has worked with a lot of famous organizations like Indian Coordinative Oncology Group, American Society of Clinical Oncology, European Society of Medical Oncology, and many other famous organizations. His he has got numerous publications in most of the esteemed journals at both national and international level. I welcome you, sir, for a few words of wisdom.
Hi, thanks a lot. First of all, I should congratulate the conducting team because this is for the after nearly 20 years. I am feeling I am doing my Viva here. so so it was such a excellent experience, and I should congratulate the candidate because she has an excellent reading for cervix. So I don't recollect her name, but I should congratulate her. So because the questions were very tough and she answered very confidently. So leaving apart that part, now we will go for the current topic, which is by Dr. Gopal Gurjar, surgical management of CS cervix. I think there is nothing to be said about Gopal except for the one word, he is a magician. So I think we should go ahead. And Gopal, I request you to start with your presentation.
Good evening, everybody. Am I audible?
Yes.
Can I share my screen now? Is my screen visible now?
No,
Yes,
no,
sir.
not yet. The screen is not visible.
Now? Is it visible now?
No, screen is not visible. Na? We cannot see his presentation. Can you see?
No, ma'am.
Huh.
Now is it visible?
No, sir, not yet. Good evening, sir.
So how do I proceed now then?
You're going to the share screen option, still it's
Yes,
not.
yes.
Piyush, can you help us? Piyush? You there?
Yes, ma'am, I already
Please.
I already gave the rights to share the screen, but I guess sir is having some trouble in his end only.
Your Mrs. Mac, Dr. Gopal?
Yes,
You're
yes, it
using
is.
Mac?
Yes.
Sometimes it happens with Mac.
So what do I
Piyush,
do now?
please help him. You can just log out and again please rejoin.
I'll leave then.
Just leave the meeting and again join.
Ma'am, if there is any issue, I can help out. I mean,
Please be there. Please
yeah, he can share his PPT and I'll share from my end then.
Yeah.
Sure.
Let him send his PPT then on your email.
Am I audible now?
Yes.
Now is my screen visible now?
No, sir. Could you please mail your
You can mail your PPT to Corona Remedies. Bhakti? So
okay, I'll do that.
So that they will start your presentation and you can talk.
ते करू शकतात ते शेअर करते.
Did you notice the mail ID, ma'am? He's messaged it
Piyush, once
Yes,
again,
ma'am. I messaged the
in the chat.
yeah.
please message in the group also so that Dr. Bhakti can get
Yes.
it.
Ma'am, I've messaged in both areas, in
Okay,
chat
okay,
and in
thank
group
you.
as well.
Thank you very much.
I can't see it in the chat box.
He has shared on the group also.
Ma'am, it is in the group also. Please check.
Please see the
Okay.
group.
Okay.
Yeah.
Hello.
Yes, ma'am. Just give me a few seconds. Piyush, I have sent it to you. Did you get it?
Yes, ma'am. I'm just checking. Ma'am, you've shared on Gmail only, right?
No, you have written Piyush at coronaremedies.com.
Yes, ma'am. Yes, ma'am. On that mail ID only, right?
Yeah.
I guess it is still in the process because I didn't receive yet.
Have you received, Piyush? Did you check again?
No, ma'am. I checked. I'm continuously checking, but I didn't get.
Okay. Bhakti ma'am, is the mail showing sent?
Yeah, let me check. I think it is sent. Let me check once again.
Ma'am, can you please check outbox? I guess it is waiting.
No, I think it has not gone.
Yes, ma'am. There must be some network issues. That is why only it is waiting. Ma'am, you can share it on group also if it is okay. I can
Yeah,
check
yeah,
it.
yeah, yeah. We can do that also.
Right. Yeah.
I can try that.
Sure, ma'am.
So, so I have to share it in the chat.
You can, ma'am. File option, through the file option.
Piyush?
Yes, ma'am.
Mail button.
Bhakti.
I'm trying with the mail again.
हा
Mail did not go
त्यांच्या
last time.
पुन्हा
I'll just
ह्याच्यावर मेल कर ना, म्हणजे त्यांना डाउनलोड करायला सोपं जाईल.
हो, मी मेलच पुन्हा ट्राय करते.
Just relax. Everyone is waiting, no problem. Huh?
Yeah, ma'am, can you CC to me too? I'll just. Ma'am, could you send?
Yeah. Just a minute.
Okay.
I'm trying from another mail account.
Okay.
Piyush, can you check now? I've sent again.
Yes, ma'am, I'm checking. Just received. I'm sharing now. 1 minute, please. Is my screen visible?
Yes.
Now is it
Sir,
visible?
yes, sir. I'll be assisting you. You can start, sir.
Acha, you will be running the slide, it seems.
Yes, sir.
Yeah, it's
Okay,
okay.
thank
We
you.
can see it. Dr. Gopal, please go ahead.
At the beginning, let me thank the organizers, Deshmukh Madam and Pragati Khadkar Madam, for this opportunity. And also, I'm very sorry for this confusion. I think this is because of the system that is being used here.
Yes, it can happen.
Without wasting time, let me begin with the presentation. As Sushil has rightly pointed out, the previous presenter had was really grilled by the two professors, and very tricky questions were asked. At times, even I was wondering what the right answer was. Next. Who's going to run the show, run these slides?
Piyush? Piyush?
Yes, ma'am. I'll be sharing. I'll be running this.
Share, please, and start.
सर ने बोले थे अपेंडिक्स का शिकायत हो सकता है
You have to run the slides.
मेरे को लिख के इसमें होता है कम मत आना इसको मन में प्रॉब्लम दर्द होगा बोलते
Taksavira, Kamniwa.
So these taking you through the journey of the hysterectomies. It's about a year, decade, a century and a half that hysterectomies have been being done, and the abdominal hysterectomy was done in 1878, and then the vaginal hysterectomy by Zerny in again 1878. So 150 years have passed that we have been knowing the art of doing a hysterectomy. Next. It was Clark who did the first radical hysterectomy at the John Hopkins Hospital in 1895, and then Verdheim's Viennese physician was the first to do radical hysterectomy with pelvic lymphadenectomy and a parametrical excision. Next. Next. So the journey starts at two places. One is the era before the World Wars, and the second is the era after the World Wars. During the World Wars, it was probably medicine had taken a backseat, and Vardheims, who had introduced the art of radical hysterectomy, fell into disrepute because of complications and unavailability of trained surgeons. It was only after the Second World War that Meigs again repopularized this art of radical hysterectomy. At the same time, Shota in 1908 popularized vaginal hysterectomies because of the complications that had happened during abdominal hysterectomies, radical hysterectomies. Next. As this was happening in the West, Okabayashi in Japan was developing his own techniques. It was the anatomy was revisited and the three supports of the uterus were established. And Okabayashi then introduced the concept of the posterior pillar as we know it today, or the posterior leaf of the vesico-uterine ligament. Next. So when Vardhans presented his first series of 270 patients, the mortality was prohibitive, 18% mortality and a morbidity rate of 1 in 3. This led to a lesser morbid procedure, the radical vaginal hysterectomy, with a lower operative mortality. Next. Next. So radiation therapy was then favored because it was not having as high mortality as surgery was. And maybe after the World War was over, Meigs reintroduced the art of surgical management of CS cervix and stated that his survival rates were in excess of 75% for a stage 1 disease. And operative mortality in trained gynec oncosurgeons was about only 1%. Next. So the problem statement in India is that over 1 lakh patients are diagnosed every year, and half of these patients eventually succumb to their disease. 1/3 of the global cancer cases happen to be in India. It is the third most common cancer in India and the second leading cause of death with a mortality of 9.1 as per Globocam 2020. So coming to the staging system, initially we were following only the clinical staging system, that is the FIGO staging system, which included a few investigations like the IVP or a barium minima and a clinical examination. This was because we wanted to compare different clinical scenarios in the third world country, this being a disease of the third world country where access to CT scans, MRIs, PET scan was assumed to be absent, and therefore only a clinical staging system was utilized. Next. So these are a few changes that have happened through 2009 to 2018 FIGO staging. 1B has been divided into 1B 1, 2, and 3, depending upon the size of the tumor, that is 5 millimeters to 2 centimeters, 2 to 4, and more than 4 centimeters. This was done primarily because it was found that patients who had 1B 1 tumor had a very good outcome. Those between 2 to 4 centimeters had moderate or maybe in between outcome, and those who had tumors bigger than 4 centimeters had more chance of local regional failure and even metastatic activity. So this staging was 1B stage was divided into 3 parts. Next. Again, as Madam has rightly pointed out, the stage 3C was introduced, which was introduction of the nodal status in this. Now, the sensitivity and specificity of a PET scan to pick up nodal activity was to the tune of 82% and 95% specificity. Next best was an MRI, which showed a specificity of 56% and a sensitivity of 56% and a specificity of 91%. And a CT scan with a sensitivity of 50% and a specificity of 92%. Meaning thereby that a PET scan is the best investigation to find out nodal activity and put the patient into a stage 3 disease. Next. So here stage 3 is divided between stage 3 C1 and 2, wherein the pelvic node lymph nodes are positive in C1 and a paraortic lymph nodes are positive in C2. Next. So coming to the evaluation part, the evaluation happens to be threefold. First is that an under anesthesia evaluation is more informative at times than even cross-sectional imaging because of the fact that the anterior and posterior vaginal wall happen to be meeting each other, and the assessment of the growth and the vaginal wall will always be incomplete unless we put in a speculum and find out whether the anterior wall or the posterior wall of the fornices are free or not. The speculum examination should precede per vaginum examination because it may lead to bleeding, and therefore it's desirable to have per speculum examination even before we actually happen to manipulate the tumor. During per speculum examination, as was rightly pointed out, we need to assess whether the cervix has been destroyed or how much of the cervix has been involved, whether the ectocervix is visible or there is effacement, or there are pre-malignant changes elsewhere. The vagina also needs to be inspected. Having done that, the per vaginum examination ensures whether the uterus is mobile or not, and the per rectum examination is done to find out whether the parametrium are involved. Next. Now, CT scan is done to evaluate whether the lymph nodes are involved or not, whether the liver is involved, whether there is obstructive uropathy, and whether there are liver metastases. Next, the MRI is the best investigation to find out whether there is parametrial involvement, and of course, whether there is stromal invasion, and to differentiate between soft tissue which is showing or harboring tumor and the soft tissue is not harboring tumor. Next, PET scan has the best predictive value. The negative predictive value of a PET scan is 92%. That is, it can diagnose organ confined disease with the utmost accuracy. So coming to the staging, I think let's skip this slide. Next. Now, what are the pitfalls of the staging system? If we are encountering a stage, maybe a stage 2A patient, and it may so happen that it is incorrectly assigned to represent vaginal involvement, clinicians may then do a general anesthesia examination to rule out vaginal involvement. In a stage 2B, it may so happen that the imaging may show stromal edema or cystic tumors or infiltration of the upper vaginal wall, and bulky exophatic tumors arising from vaginal portion of the cervix may then be misinterpreted. And even for that matter, a 4A or locally involved, locally aggressive tumor may be misrepresented on a cross-sectional imaging as having invaded the bladder or rectum. So, of course, clinical examination is of utmost value. Next. If you look at this slide, this is taken from Harrison's principle of internal medicine. The 5-year survival is a function of the stage of the disease. Now, the stage 1 disease, organ confined disease, the survival or 5-year survival would be in excess of 85%. And this happens to steeply fall to 7% when it is a stage 4 disease. If we happen to see this second row of representation, that is the stage at presentation, in our third world country, it is majority of the patients are presenting in stage 3 disease, wherein the 5-year survival rates are in the ranges of 35% only. Next. There is a lot of data regarding whether surgery should be offered or radiation should be offered. The largest study accounting for maybe 5,000 patients said that for tumors which are less than 4 centimeters, surgery would be a preferred therapy than radiation. Next. Now, comparing what radiation has to offer versus surgery, radiation can be offered to moribund patients, but the flip side is that the ovaries get destroyed, the vagina is fibrosed, there can be bowel fibrosis, radiation cystitis, radiation proctitis. Both the procedures carry equal control and cure rates as well as equal morbidity and mortality rates. Next. We can skip this. Next. Next. So what are the contraindications to operate? The contraindications include medically unfit patient or a patient who refuses surgery, but more importantly, where there would be a requirement to give additional adjuvant radiotherapy in an early stage disease, or where there is parametrial involvement, or there is grossly positive pelvic and para-aortic lymph nodes. Next. Now this is the journey that we have had. Now the latest addition to our knowledge has been the nerve-sparing radical hysterectomy, which has been proposed by Fuji, and the classification has come up in 2007. And Dargent's fertility preservation trachelectomy, as was talked in the case. Next. There are several classifications of a radical hysterectomy depending upon the Piver system or the more recent Morose system and the extent of excision that is offered in them. From a simple extrafacial hysterectomy to pelvic exenterations when they are done for anterior or a posterior exenteration of the anterior or a posterior extension of the growth, which happens rarely. Most of the times it is lateral extension, which makes the disease unresectable as such. Next. Now, these are some terminologies which are recently added to this procedure. Total extirpation of interiliac blood vessel system with cardinal ligament. Here you can see the interiliac vein and its tributaries, the inferior gluteal vein, the internal pudendal vein, the deep uterine vein, and the obturator vein. This entire venous system is knocked off, and the obturator fossa is totally cleared of the fibrofatty tissue as well as the venous system. Next. These are the levels of transaction of the vessels. Next. And this is what we can expect after having removed the entire blood vessel system. Next. Now, this is the anterior and posterior view of the specimen. The ventral view where we can see and appreciate the cardinal ligament, and the dorsal view where the uterosacrals need to be knocked off with a sufficient margin of maybe 4 to 5 centimeters beyond the cervix. Next. The three supports of the uterus, the uterosacral, the cardinal ligament, and the basico-uterine ligaments need to be tackled as far as possible, or for that matter, even a planned procedure, we need to clamp them at the pelvic side wall or at the sacrum or at the bladder base. Next. These pictures are taken from a book by a Japanese author, and I'll quote that book at the end of this presentation. Very beautiful book, which has been written on the neuroanatomy of the nerve-sparing radical hysterectomy. So first and foremost, after opening the abdomen and ruling out excessive and extensive disease, we open the broad ligament to identify the uterine artery. Next. And the ureter is identified underneath the uterine artery. Next. Then we put a posterior cut and cut the posterior peritoneum to expose the uterosacral ligaments. Next. Then the uterosacral ligaments are controlled at a sufficient distance and margin beyond the cervix. Next. These are the several spaces that need to be created: the paravesical space, the Latko's pararectal space, and Okabayashi's pararectal space. These two pararectal spaces are different in terms of their potential for nerve preservation. Next. Again, a representation of Okabayashi's pararectal space, wherein the hypogastric nerves are can be identified and can be sacrificed if there is extensive disease in the parametrium, or they can be preserved if there is low volume disease. Next. Once that has been done, the cardinal ligament is divided to expose the splanchnic, pelvic splanchnic nerves, and deep uterine vein. Next. Then they are clamped and divided. Next. Once that is done, the levator muscle will be exposed underneath, and the specimen can be mobilized, can be made more loose from the same side. The same things need to be repeated on the contralateral side, and then we move to the anterior dissection. This is the opening of the anterior pillar, or what we call as the anterior leaf of the basico-uterine ligament. Once this is done, the ureter can be lateralized, and then we can tackle the posterior pillar, or that is the soft tissue which is in relation to the lateral aspect of the vagina. Next. Here the paravaginal space is documented with the cut end of the anterior pillar, and the posterior pillar can now be seen. So when the posterior pillar is divided, we can go on to the paracolpos, that is the tissue in lateral direction of the vagina. Next. Here the posterior pillar is divided. Next. And then you can see the paracolpos, that is the tissue in the lateral direction of the vagina. Finally, the specimen is to be removed after division of the rectovaginal ligament, which totally frees the specimen from the attachments in the pelvis, and it is then held only by the vaginal mucosa. Next. So here you can appreciate what the Okabayashi's paravaginal space is like. It is a space which is created medial to the posterior pillar and the vaginal wall. Next. So different aspects of where the parametrium is divided in the Vardines procedure, what is done is that the uterine artery and the Mackenrott's ligament along with the pillars are transected with a single clamp. In the Meeks method, what is done is the uterine vessels are taken at the pelvic side wall, and then the Mackenrott and the anterior pillar are taken in the same clamp. But the most comprehensive one being the Okabayashi's method, wherein the vessels are ligated at the pelvic side wall, the Mackenrott's ligament is taken, and then the anterior and the posterior bladder pillars are tackled, and the paracolpos is also taken as additional margin for the lateral extent of the vaginal margin. So the same surgery can be dealt with by laparotomy, by laparoscopic route, and now recently by the robotic route. The oncologic outcome seems to be the same in all three approaches. However, when the growths become larger in size, a laparotomy is more preferred, and a laparoscopic approach may eventually endanger oncologic safety. Next. So I have got the snaps of a patient which I did about 7-8 years ago. So this patient was a 45-year-old lady having she had bleeding PV of 3 months duration, and an MRI showed a 3.5 by 3.5 by 1.8 centimeter cervical mass, and had some perirectal fat involvement, and was actually advised chemoradiation at that time. Next. These are the MRI films. You can see at the extreme left, there is some invasion or there is a spike of tissue which can be seen almost entering the rectum. Now, this was a fallacy of the MRI, which we had resolved on evaluation under short GA. Next. Another cut, the parametrium is very well seen on an MRI. Now, this is a negative image where you can see the gray cervix and a T1 weighted image, and the parametrium, which is seen as white signal. Next. Again, the stir sequences may be confusing at times, wherein the distinction of the line of cleavage or the plane between the bladder and the cervix may not be visible at times. Next. Now, this is a negative image which showed that if we closely see, the pararectal fat is totally free of invasion. So this gives us a chance that we actually can go in and operate. Most of the cervix happens to spread laterally and not anterior or posterior. So anterior and posterior excentrations are largely uncommon surgeries for CS cervix. Next. So the procedure was done under spinal epidural anesthesia. And next. After draping the patient from the pubic symphysis to the xiphoid, vertical incision is planned. Next. This is the constant exposure through a self-retaining system. We use a chest spreader or a Thompson retractor at times if the patient is heavy. Next. Here the round ligament is divided. Next. The IP ligament is divided high up in the pelvis so that we can have ease of dissection when we are attempting pelvic lymphadenectomy. Next. Here the spaces are being next. Here the spaces are being developed, the paravesical space and the pararectal space. You can appreciate the ureter in the medial fold and the uterine vessels crossing the ureter. Next. Another snap of the spaces being created. Next. Next. So the paravesical space is bounded medially by the obliterated umbilical artery, laterally by the obliterated internal muscle, posteriorly by the cardinal ligament, and anteriorly by the pubic symphysis. Next, the pararectal space is bound medially by the rectum, laterally by the hypogastric artery, posteriorly by the sacrum, and anteriorly by the cardinal ligament. So once that is done, the uterine vessels are controlled. You can appreciate the mixture being passed underneath the uterine vessels and the ureter being secured. This is a very typical dissection of the uterine vessels over the ureters. Next. Once that is done, the anterior pillar is tackled. Now this anterior pillar contains the superior vesical veins and the small vascular channels which connect the bladder base to the cervix. Next, the same thing is done on the contralateral side. Next, the left anterior pillar is tackled. Next, you can appreciate here the anterior pillar has been hooked on a mixture forceps, and then the tissue is being bipolarized. Here it's prudent to use bipolar dithermy so that the current doesn't pass on to the bladder base, and injuries to the place to the bladder base and the vesico-ureteric junction do not happen. Bipolar energy is very safe here. Once that is done, the specimen is pulled, is given traction caudally so as to expose the uterorectal space. Once the peritoneum is divided, the length of the uterosacral ligaments will be established. Next, here the uterosacral ligaments are divided far away from the cervix. Next, again another picture showing the lateralization of the ureters and the growth being seen. Once that is done, clamps are put. If we are very certain that the cervix, that the vagina is free, clamps may be put so as to avoid contamination and spillage. Or if we are, or if the vagina is involved, then we need to do a colpotomy and excise the vaginal growth with adequate margin. This was a case where there was a wide cervix and these fornices were technically free. So a closed technique was used. Next. Subsequent to that, a pelvic lymphadenectomy is done on either sides. You can see the external iliac artery vein and the obturator nerve in the depth. Next. Next. Once the specimen is removed, the ureters fall medially, and you can appreciate the pelvic anatomy here. Next. So a specimen should be rectangular in shape, suggesting that the uterosacral and the cardinal ligaments have been resected far away from the tumor. Next. Then the specimen was cut open. This shows the margins on the vaginal side as well as the parametrial side. Next. This was one more case where the tumor was almost 8 centimeters across, but the point was that the fornices were free and the histopathology was suggestive of an adenosquamous malignancy. Now, when a malignancy is having a biphasic nature, the adenocarcinoma element has got poor response to radiation. So in that situation, we should err on the side of surgery rather than on the side of radiation. Next. 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 Now, this was one case of CA vagina wherein we had to do a lap hysterectomy along with the excision of the entire vaginal tube. Very rare case. Next. Now, this patient on follow-up had no technical vaginal lumen. Next. Anterior exentations are to be done only if the patient is having a fistula into the bladder or ureteric involvement. As such, radiation-induced fistulae are the commonest indication of doing exentations now, because we have done about six exentations for fistulae, and these exentations were possible only because the disease was controlled, number one, and number two, the disease had no lateral extension. A radical cystectomy needs to be added to this, and an ideal conduit for urinary passage needs to be created. Next. Posterior exentations are common for rectal fistulae, and the most common indication being C rectum in a female patient, which can be dealt with laparoscopically as well. Next. So I was talking about this book, Fuji, who has given this classification. This is a very good book available on internet, and very lucid images are there, and one can understand how radical hysterectomy is planned just by going through the pictures in this book. They are really well written book. Next. He is a very famous surgeon, Deepak Limbachia sir. I think his videos on YouTube are very, very informative, and I myself do follow his videos. Open surgery is very difficult to record, and perhaps even the photographs in an open surgery are not as informative as a video can be. Next. Another rare case of CA vulva. Next. Next. This was covered with a butterfly flap. Thank you. Next. I'm sorry for the problem which we had to face because of the, I think my Mac is not updated. That's the reason why I could not show the presentation through my machine. I'm sorry for that.
No problem, sir. Yes, ma'am.
It was a wonderful presentation, sir. Yeah. Mesmerized. So very good pictures and very good slides. Sir, if you could share them with us, or Prachi, if you could get the recording or something.
Ma'am, recording would be available all the time. Like, we
Okay,
just share the
yeah.
link immediately. Yes.
Sure, fine.
The Corona people
Pictorial
actually
representations have
record
been
each and
taken
every
from that
webinar.
book
Okay,
by
ma'am.
Fuji.
Yeah.
Yeah,
And
very nice.
that book has got very good lucid images, which we can very well understand. I think none of these atlases till date are so precise in their understanding of anatomy as this book is.
Very clear
So actually
presentation, sir. Yeah.
Yeah. And Dr. Shuchi, actually each and our webinar is recorded by Corona people and they
Okay,
share
ma'am.
with everyone. So it will
Sure.
be shared, no problem. So we have captured all the important things from Dr. Gopal Guzes and all
Okay.
your stuff.
Yeah.
And really,
Thank
it
you,
was very
sir, so
nice,
much
Dr.
for
Gopal
your.
Guzes. Your talk was very nice. Yeah, continue, please.
Thank you, sir, for enlightening us with such a wonderful presentation. And now, as we are moving towards the end of today's event, now I'd like to invite on screen Dr. Pragati ma'am for the vote of thanks.
Okay. Very good evening to all. It was indeed a very interesting session. So I'm glad that today we are at the 15th series of our PG Star, and this PG class is going on so well and is so much appreciated all over the country, and so many other beneficiaries who are attending and getting benefited from it. And I was so impressed to get a call from right from Jagdalpur in Korean MP that a practitioner, she's told me, I regularly observe watch all your PG stars, and it is really helping me to enhance my practical and skills. So we are all thankful for this wonderful idea of our President, Madam Dr. Sushma Deshmukh. And this is my honor that today MJIMS has joined us for this unique program. Today's presenter, Dr. Supraja, was excellent with her case. Thank you, Supraja. And today's examiner, Dr. Leela Vas, right from Jaipur, Dr. Anuja Bhalerao, have been a wonderful examiner, and they have given a very good insight on the case of CA cervix. And today's star speaker, Dr. Gopal Gurjar, whom we are trying to coordinate since so many days, and today was our lucky day that we could hear him, and so beautiful presentation with beautiful pictures and such a good, varied experience of all type of malignancies. Thank you, sir, for attending our program. Today's chairperson, Dr. Shuchi Jain, and Dr. Sushil Mannadia, thank you for being with us. And MOC was Dr. Toshali Panda, thank you so much. And our pillars of PG Star, three corners of our star, Dr. Prachi Dixit, Dr. Bhakti Gurjar, and Dr. Anuja Balarao. Thank you for bringing so good platters for all our, all the members of Foxy, I can say. Thank you so much. And last but not the least, all the delegates who have joined in and Corona people for making this program happen. Bhakti, today you should get a special thank.
Today is Bhakti's day. Yeah. And actually, we could get Dr. Gopal Gurjar because of Bhakti.
The star faculty. Thank you so much.
And thank you very much for being here.
No, nothing like that. Also a member of our NOGS family only.
Yes. So this was
Thank you, ma'am. Yeah, thank you, sir. Yeah.
This star was after post Diwali, after a gap, and it has really taken us all to the deep academics, and it was a good one to get into this class after, oh my God, I think 3 weeks. Now, Bhakti, this time it was after 3 weeks.
Yes, after 3 weeks.
Yes. We had one week break because of Diwali.
Yes.
Yeah. So the PG Star ka silsila chalta rahega. So all the delegates stay tuned with all our programs.
But be registered for the carnival, the grand
Sure,
event
ma'am.
of the year.
Yeah.
About hysteroscopy.
Log into www.nogs.in. Very simple.
Yes. Present paper.
nogs.in. Remember, you will get everything over there.
Posters win so many prizes we have kept for our hysteroscopy carnival. So I request all the PGs to do present, to come to Nagpur and to have best experience from the international faculties who are going to show live operative workshop, simulator workshop, PPH workshop, and all interesting sessions. 14th, 15th, and 16th December in Nagpur. For
15, 16, 17. 15, 16, 17.
Sorry for the mistake.
No problem. 15, 16, 17 December.
Yes.
Okay.
Thank you.
Thank you. Thank you, Tushar.
Thank you.
Just for the PGs, I will also share the link for submitting papers and posters in the chat box also. All the PGs who want to present their papers and posters, please go through it.
Yeah, please, Dr. Bhakti Gurjar is looking after it. So please talk to Dr. Bhakti if you are having any problem. And please, you can share your wonderful work over there. Okay. Then. So thank you, everyone. Thank you very much for being here on this platform. Bye-bye.
Thank you, ma'am. Bye, ma'am. Good night.
Bye. Good night.
Yeah.